Hello friends, welcome to my channel. Meds up. I am Dr. Tehsim and today we are going to discuss angina pectoris. Okay, it is also known as typical or stable angina. Okay, so we are going to first learn definition, which is actually angina is chest discomfort more than chest pain. It is usually attributed to myocardial ischemia and it occurs when there is mismatch of myocardial oxygen supply and demand. So first we are going to learn about perfusion of heart. There are epicardial vessels which divide into prearterioles, arterioles, and last is capillaries. Okay, so from epicardial vessels to arterioles, diameter decrease and resistance increases. Okay, so normally perfusion of heart is by coronary perfusion pressure. Okay, so coronary arteries arise from aorta, aortic sinuses. Okay, so blood goes from aorta to the coronary arteries during diastole. Okay, so from aorta, so you need a pressure gradient between aorta and coronary arteries. Now the thing is that epicardial vessels are responsible for patency of lumen of vessels, and prearterioles and arterioles are responsible for dilatation of the small vessels whenever required. Whenever there is, as for example, if the perfusion pressure, coronary perfusion pressure decreases, or if there is any ischemia or stenosis of epicardial vessels, then prearterioles and arterioles will usually dilate and supply blood to the heart. When this does not occur, there is a type of angina that will learn ahead will lead to that type of angina. So first of all, causes and types of angina. So first type is causes and types of myocardial ischemia. Okay, so first is there is fixed obstruction, fixed epicardial coronary obstruction, which is also known as macrovascular obstruction. Most common cause is atherosclerosis. Overall, most common cause of angina is atherosclerosis, which leads to stable or chronic type of angina. Second is microvascular obstruction or microvascular angina. That means this small prearterioles and arterioles are unable to dilate whenever it's needed, and it leads to angina. For example, during exercise, and this kind of angina is also known as syndrome Y. Okay, then third type of angina is variant or vasospastic or Prince-Matters angina, which is due to coronary vasospasm, and last is unstable angina. So today we are going to discuss mostly stable angina. Okay, so first pathophysiology of angina, stable angina. There's a mismatch between O2 demand and O2 supply. So O2 demand increases by few factors and O2 supply decreases. So what are the factors that increase O2 demand? First is increase heart rate. So anything that is leading to increase workload of a heart will lead to increase O2 demand. The first is increase heart rate, which can be seen during exertion or stress. It can be physical or emotional stress like anxiety. Okay, and cold also increases the O2 demand of heart. Then increase afterload means a load against pressure against which heart has to pump blood. Okay, so it is seen in systemic hypertension where there is increased peripheral vascular resistance. Then increase myocardial contractility, more muscle, more contraction, more O2 demand seen in LVH and RVH, that is left ventricular hypertrophy or right ventricular hypertrophy. LVH is seen in systemic hypertension and RVH is seen in pulmonary hypertension, especially in COPD. Then high myocardial wall tension, which depends on two factors. First is preload or ventricular end diastolic volume, that is blood volume that is present in ventricle at the end of the diastole, that is after the ventricular filling. Okay, and last is second is myocardial muscle mass. So again, more muscle mass, more O2, more wall tension and more O2 demand. Okay, so these are the factors which increase O2 demand, and compared to that, there is increased O2 supply. So what happens is oxygen carrying, it depends on two factors. First of all, it depends on blood, that is oxygen carrying capacity of blood, which depends on hemoglobin. So anemia, there is decrease hemoglobin, decrease O2 carrying capacity of blood. Plus anemia also leads to tachycardia and hyperdynamic circulation, so it also leads to increase O2 demand. So there is so that's why some people like severe anemia presents as anemic heart failure. Then second is coronary blood flow. Second factor that O2 supply depends on is coronary blood flow. Coronary blood flow depends on coronary artery diameter. If it is more than 70% obstructed or stenosed, like seen in atherosclerosis, okay, then it can lead to angina. Then coronary artery tone or resistance, as we discussed, it needs to dilate when it's needed, and if that change in tone or resistance is lost, especially seen in arteriosclerosis, okay, then it can lead to angina. Third is perfusion pressure. As I explained before, you need a pressure gradient from aorta to coronary arteries, as coronary arteries arise from aorta, and it happens during diastole. During diastole, coronary arteries get blood. Okay, so this is an important factor. And blood supply from epicardium to endocardium depends on left ventricular and diastolic volume. Okay. Then fourth factor that coronary blood flow depends on is collaterals. More the collaterals, less are the chances of symptoms, and it will be delayed angina and myocardial ischemia. And last is duration of diastole. Because I explained you that during diastole, aorta pumps blood into the coronary artery. So whenever there is a decreased duration of the diastole, there is decreased time for coronary blood flow. That usually happen in tachycardia. Tachycardia means increased heart rate. That means increased beats per minute. So that means there is increased systole. So there is a less time for diastole, and so less time for coronary blood flow to occur. Okay, so in this video we have discussed pathophysiology. In the next video we'll discuss clinical features and management of angina. Okay, if you learn from my video, please like, share, and subscribe to my channel. Thank you.